feel that of the conditions that we have thought of, abstinence anomaly is more likely because X-ray, everything is in favor. Okay. Now, what is the echocardiographic finding? Saroj, you can just tell that.
I have values. So should I go for the values also?
No, if you can just read or you can describe the values, that will be great.
Yes, yes. 1 minute. Sorry. The rejection fraction is showing 59%.
Okay.
And sir, 1 minute, sir. LVI only 1.9. Okay, sir. LA is only 2. And sir, RV, sir, they have. So they have not written the RV measurement only. Sorry. So I did it. This is my handwriting only, sir.
Okay.
So RARV and large, there is severe TR. So there is incomplete closure of the tricuspid valve, and the septal leaflet of the tricuspid valve is displaced apically. And so PAP was pulmonary artery pressure. It was coming 45, so little high, and so IVC was dilated.
Oh, so pulmonary artery pressure elevation, which is a bit odd for Abstinence anomaly. Is she having any respiratory pathology?
No, sir. No, sir. No.
Because otherwise you cannot explain the pulmonary artery.
Some left heart disease she might have had.
Yeah, they should have either left heart disease.
Left heart disease.
Even if there is a left heart disease, if the patient is she having an atrial septal defect?
Sir, there was a echo drop present, but sir, flow I could not see, sir.
Okay, because there is either an atrial septal defect or an opening up of the foramina veil to explain the cyanosis. So that is there.
Yes.
So the pulmonary artery,
I could not see the. So that was they have given the report. The type report, RA dilated, no regional volume, adequate LV, mild MR, severe TR. Sir, there was an echo drop I could see, sir.
Oh.
And sir, how much?
No. Obviously, there is a right to left shunt because you have recognized that the patient is having some degree of cyanosis and oxygen saturation is only 85%. So either it could be an ASD or it could be an opening up of the foramina veil resulting in a right to left shunt. So that is there. So a few points of discussion on Abstinence anomaly. So what is your diagnosis now? Full diagnosis?
Situs solitus.
Very good. No, you should start with congenital heart disease.
Okay, Levocardia. Yes, sir. Congenital cyanotic heart disease. With a normal pulmonary blood flow, sir.
Okay.
Dominant RV.
Why did you say no dominant RV? Because you have felt the apex beat is LV and mild parasternal lift. You don't use the dominant RV, you skip it. RV failure, that is enough.
Sir, yeah, sir. I was typing. Sir, it is wrong, sir, I think.
RV failure?
RV failure, possibly due to Abstinence anomaly.
Why did you say possibly? It is Abstinence anomaly because we have clinically by echocardiography, everything X-ray wise, we thought it's Abstinence anomaly. You can definitely diagnose Abstinence anomaly. Yes, okay. And what are the now coming to Abstinence anomaly? Have you read about it, Saroj? So Abstinence anomaly, which cusp is involved?
Sir, it is the septal leaflet of the tricuspid valve.
It is displaced. And what is the other leaflet that can be involved?
Sir, anterior leaflet.
What about the posterior leaflet?
Sir, posterior leaflet usually remains normal, sir.
Posterior leaflet remains normal. Or okay. So what are the abnormalities that can happen in the anterior leaflet?
Sir, anterior leaflet is displaced apically, and sir, there may be, sir, sometimes it may be dysmorphic. So, sir, we can get some gradient also.
Okay, they can get attached to the RV outflow, giving rise to gradient. Monica, do you agree with her that it is the septal leaflet and the anterior leaflet which are displaced and posterior leaflet never gets displaced?
No, it is the adherence of the septal and posterior leaflets to the underlying myocardium. And hello.
Yes.
Basically, Abstinence anomaly, anatomically, it is the adherence of septal and posterior leaflets to the underlying myocardium. And what causes is the downward displacement of the annulus. So there is a dilatation of the atrialized portion of RV and thinning of the free wall of RV.
Okay.
And the anterior leaflet is usually redundant. Mostly, it may be redundant, it may be fenestrated, or it may be tethered. So that gives rise to all the findings.
Okay. Now, usually the most prominent, the important leaflet which gets displaced is the septal leaflet. That is the one which always gets displaced. And it may be 2 times one the actual displacement, or as Monica has rightly pointed out, it could be a tethering of the septal leaflet to the wall of the interventricular septum. And usually, what will be the degree of displacement for us to diagnose Abstinence anomaly?
Sir, 8 centimeter per square meter.
8 centimeter.
8 mm.
8 mm. 8 mm.
Per meter square of body surface area. But usually in kids it is 10 mm, 10 mm, and in adults it is considered as 20 mm.
No, 1.5. If it is more than 1.5 mm in an adult, that can be considered as evidence of abstinence anomaly. Or but if you want to be very correct, you can say that 0.8 centimeters or 8 millimeters per meter square body surface area. That will be the displacement. The posterior leaflet also can be displaced in abstinence anomaly, but the anterior leaflet is never displaced. It is large, it is sail-like, and moves over a large distance to close the tricuspid valve. But sometimes it can be attached to the RV outflow, giving rise to RV outflow obstruction. So some of these patients can have RV outflow obstruction, and whenever there is a RV outflow obstruction, what is the effect on tricuspid regurgitation?
It will increase. Sir.
It will increase. The RV pressure will increase, and I would presume that in this patient, the pulmonary artery pressure might have been measured based on the tricuspid jet. And there's a good possibility that this patient, because of the adherence of the anterior mitral leaflet onto the RV outflow, giving rise to some degree of RV outflow obstruction, and that should be the reason why RV pressure is 45 and pulmonary arterial hypertension may not be the correct diagnosis.
Sir, by TR.
It is by TR. So RV systolic pressure is elevated, maybe because of the abnormality of the anterior mitral leaflet, and which may be adherent partly to the RV outflow, giving rise to RV outflow obstruction.
Yes, sir.
Okay. Now, what are the complications of abstinence anomaly? And what is the most important thing which decides the life expectancy of patients with abstinence anomaly? Complications and most important.
Sir, it is how much displaced the leaflet is. How much accumulation of the RV that decides that.
2 points. One, degree of displacement, and second, RV function. When the patient develops RV dysfunction, they have got every possibility that they may steadily deteriorate, and then they have got a bad prognosis. And the patients with significantly displaced tricuspid valve with severe tricuspid regurgitation more often can develop early RV dysfunction. Okay. Now, what are the complications of abstinence anomaly? Complications?
Arrhythmias.
Yes, atrial arrhythmias.
Then, if patient has WPW, even SVTs and VT can happen.
Very good. The patients with the WPW has got a risk of developing supraventricular tachycardia and also sudden cardiac death because of these patients can go, especially with atrial fibrillation, they can go in for fast ventricular rate, and sometimes it may be detrimental. If you are doing a cardiac catheterization, is there any finding which will help you to diagnose abstinence anomaly?
Yes, sir. Sir,
Yeah.
when we are entered into the RV, then even sir, we will get the waves of the right atrium.
What did you say?
Sir, atrialized portion of the RV, in the atrialized portion of the RV, sir, we will get the waves in the form of, atrial waves will be seen in that part. And sir, one more ECG also, intracardiac
Intracardiac ECG?
ECG is also sometimes helpful.
How it is
also helpful. That how much helpful, sir? We will. Sir, I don't know, but sir, some intracardiac ECG is very helpful, sir.
No, yes, sir. What is it? I'm asking you, what is it? Monica, would you like to give a comment?
Yes, sir. Even if the ECG lead is placed in atrialized portion of RV, atrialized portion of RV, it will sense the atrial pulsations.
What do you mean by that?
So, sorry, I put it wrong way. So, when you are doing an intracardiac electrocardiogram in an
intracardiac electrogram, don't use the electrocardiogram, intracardiac electrogram.
So RA will have the normal tracing. RV, even if the lead is placed in RV, it will show the atrial waves.
Not completely right. See, it is like this. When you are doing a simultaneous pressure recording, in a patient with abstinence
will be RA pressures, but
when in an area where you are getting an RA pressure, you will be able to get ventricular morphology intracardiac electrogram.
Okay.
See, it is an atrialized portion of the ventricle. In that atrialized portion of the ventricle, by electrogram, you will be able to get ventricular electrogram, while the pressure recorded will be that of the right atrium. So in atrialized portion, you get pressure recording that of the atrium, and you get a ventriculogram, electrogram, which is that of a ventricular, that of the ventricular complex. The electrogram will simulate the electrogram that you will be getting from the ventricular cavity, while the pressure will simulate the one which you are getting from the right atrium. So if you are getting this dissociation, where the right atrial pressure and the right ventricular electrogram, that is diagnostic of abstinence anomaly. But nowadays nobody does that, because echocardiogram will immediately give you the diagnosis. And management. What is the management? Surgical management? What is the surgical management?
Is indicated in patients with NYHA class 2 or more.
Yes, very good. The patients who are symptomatic.
Presence of cyanosis and cardiothoracic ratio of more than 65% on chest X-ray, which is evidence, level of evidence, I think, class 1B.
Class 1B or no, class 2A, class 1.
Sir, exercise intolerance is class. Hello.
The patients who start developing symptomatic patients, especially those patients who are starting developing the features of RV failure, are candidates for a surgical repair. I don't remember exactly what is the class that you have to verify. And
presence of cyanosis. Severe tricuspid regurgitation with symptoms.
Yes, very good.
And
symptomatic patient.
Yes, sir. Symptomatic patient, TIA or anything, paradoxical embolism is also an indication for surgery.
Yes, it's an indication. Yes. What is the surgical treatment? What is the surgical treatment? What is the surgery? You can re-implant the. You can re-implant surgical. The tricuspid valve can be re-implanted. And mortality? In centers where this surgery is being done, in specialized centers, the mortality is less than 5%. They have got a very good prognosis and they do extremely well. Patients with abstinence anomaly. Okay, I think any other point you would like to discuss? What about radiofrequency ablation for
WPW syndrome? Yes, sir.
So these patients
Yes,
can undergo radiofrequency ablation for WPW syndrome, especially if the patient is having atrial fibrillation. It's extremely important that the axillary pathway should be ablated. Okay, what about pregnancy in these patients, abstinence anomaly? If the patient is not in RV failure, if the patient is having only tricuspid regurgitation, usually they tolerate the pregnancy reasonably well and they can go through normal pregnancy and normal delivery. But if the patient is having RV failure and symptomatic, some of them may deteriorate and that may be detrimental. So RV function is the most important single factor which decides the prognosis in patients of abstinence anomaly who become pregnant. Okay, very good. I think it's a very good case. Saroj, you brought a very good case and we had plenty of opportunity to discuss. Excellent. Very good. And I think you discussed it also very good, very well. Monica, I think you did very well, extremely. Are you a final year student? Both of you?
Sir, I'm final year student.
Final year. And Monica, you are also a final year.
I just passed out.
Oh, you passed it. Oh.
Just now passed out.
Oh, are you still working there as a, in the department now?
Yes, sir. I'm working with Dr. Tom, sir, right now.
Okay.
In the department to polish my skills a bit.
Oh, I see. Especially you want to polish your skills in interventional cardiology, eh?
Yes, sir. Yes, sir. Interventional cardiology and some pediatric interventions I need to get myself trained for.
Are you a pediatrician who became a cardiologist?
No, sir. I am from medicine faculty.
Medicine, okay. I think good case, good discussion. Everything went on very well. Next week, what do you need? Do you want to have a somebody suggested that I would like to have a class on second heart sound, and I think I can take that. There is no problem. Would you like to have that, or would you like to go for another case discussion? What do you like to have? Manjunath, what would you like to have? Or would you like to bring a case? Manjunath, would you carry?
Second heart sound is okay, sir.
You want to have a discussion on second heart sound? Yes, that can be done, no problem. And then the second heart sound discussion, it may be over a period of maybe 45 minutes or 1 hour. So if you want, you can have one more topic. Would you like to have another topic? We can have a short discussion on
clicks.
Okay, we can have, or maybe we can have a discussion on systolic murmurs, how the mechanism of protection, what are the different types of systolic murmurs. So I think that can be. So we can have two topic discussions. One is the second heart sound, and another is systolic murmur. Okay, good. Okay, right.
Thank you so much,
it was a very good discussion.
Sir,
Excellent.
sir, just one comment I want to make.
Okay.
All your classes has made a lot of difference to my clinical examination and answering all examiners. Thank you so much for all the teachings.
Oh, thank you, Monica. Thank you.
It's been an honor to learn from you, sir.
Oh, thank you. I think if you have benefited, I am greatly honored, and I am actually the teacher of your teacher.
I know, sir told me.
Tom is my student. He's one of our very good students. And actually, he's a classmate of my son also. See, my son also studied with him.
Okay, great, sir. I'll convey your regards to him, sir.
Oh, please. Okay.
Yes.
Okay, right. Thank you. I think next week we'll meet and we'll have a discussion on second heart sound and the mechanism of production of systolic murmurs. Okay, right. Great.
Thank you, sir. Thank you, sir.
Thank you. Thank you.
Thank you.
Thank you.
Thank you. Bye.
So thank you all. From here, I'm ending the meeting now.
Thank you.